Good evening to each and everyone over here. I'm thrilled to welcome you all for today's informative webinar on why bronchi dilate, a complete guide to bronchiectasis. I'm Vijay, manager at Mediversal Academy, and I have the privilege of introducing our esteemed speaker for the day, Dr. Sohail Mohammed. Dr. Sohail is an accomplished respiratory medicine specialist and academician, currently serving as assistant professor at Al Amin Medical College, Vijaypur, a university rank holder in MD Respiratory Medicine from RGUHS. He has also earned top honors, including first prize in 34th Pure View quiz conducted by CERES Crest. He previously served as assistant professor at Kanchur Institute of Medical Sciences, Mangalore, and he is an active contributor to medical education as a CME speaker and postgraduate presentation in moderator. Dr. Sahil's work reflects a strong commitment to teaching, research, and advancing respiratory healthcare. Over to you, doctor.
Thank you. Thank you very much, Vijay, for your kind introduction. Just give me a 30 seconds. I have some technical glitch. Just 30 seconds, okay?
Sure, doctor, sure.
Hi, good evening, everybody. Sorry for the delay. There was slight technical error. So I hope we can start. I'm going to share my screen. Can you see the screen, Vijay?
Yes, doctor. I can see.
Okay, all right. So let me keep a chat box ready so that today's session is interactive. So I want to see how people will interact. Okay. Yes. Hi, everybody. Good evening. I hope I am audible and the screen is visible to everybody. So let's just start today's webinar, which is why bronchi dilate, and it's a complete guide of bronchiectasis. I have tried to cover almost the entire aspect of bronchiectasis. So let us begin with today's webinar. Before beginning this webinar, I just want to ask everybody, how many cases of bronchiectasis do you guys see in your daily practice, or whether it is OPD or IPD or as a reference? So I just want to know how many numbers approximately in a day. If not in a day, at least in a week or in a month. Any diagnosed case of a bronchiectasis? Okay, so let us begin. At what stage do we usually diagnose bronchiectasis? Do you think we diagnose bronchiectasis at an early stage, or do you think we diagnose it at a very later stage of the disease? So first thing is when hemoptysis appears. I think most of you will agree when hemoptysis appears, we tend to diagnose towards the bronchiectasis. So that is again in the latest stage, or any patient who is having recurrent multiple hospital admissions, or when the HRCT finally gets ordered, where we can see the picture in front of our eyes, then it is said to be diagnosed as bronchiectasis. But please remember, all these three are at very later stage. Okay, they are not in the beginning stage of the bronchiectasis. So when we hear bronchiectasis, many of us will immediately think of hemoptysis. Yes, definitely, because any patient who is coming with a massive hemoptysis, one of the differential diagnoses to be kept in the mind is bronchiectasis. And you can understand that hemoptysis is often a very late manifestation. Okay, that means that this is a consequence of years of silent airway damage. That means there is a ongoing silent airway damage inside the lung. Okay, but the hemoptysis appears at a very later period of the disease. So by the time bleeding occurs, the structural destruction has already happened and it will be a major destruction to the lungs. So again, my question is, are we recognizing it early enough? Like, how often do we see a patient who is labeled as bronchial asthma or a chronic obstructive pulmonary disease or a post-tubercular sequelae or complication who keeps coming to you with recurrent infection? And the chest X-ray of that patient shows very non-specific changes like some minimal infiltrates or increased bronchovascular marking. So we treat the episode. Okay, we just treat the episode and we don't evaluate it further, thinking it as an exacerbation, and we just give some antibiotic. But the cycle continues and there is a production of sputum in day-to-day life, and the infection keeps on recurring, especially in the same region. And at a period of time, these exacerbations are disproportionate, out of proportionate to their disease. So at that time, we should ask ourselves, is this just an inflammation or more than that, like a structural airway disease? Because when we treat these infections or exacerbations with the antibiotic, they just treat the infection part. The underlying inflammation, the damage, the distortion of the architecture is not corrected by these antibiotics. So why we should wait for hemoptysis for a patient to be labeled as bronchiectasis when the bronchiectasis itself can be diagnosed earlier and the progression of the disease can be prevented? So my aim of today's webinar is to make you all aware and make you all very well to diagnose bronchiectasis before the hemoptysis appears and at an early stage. So let us begin with a case. We have a 42-year-old female who is known case of bronchial asthma since 8 years, and she complains of a chronic productive cough over last 3 years, and she has a daily expectoration of yellow sputum, which is more in the morning, and she gives history of 3 to 4 exacerbations every year. But during these exacerbations, the doctor used to prescribe temporary antibiotics, and she used to get improved with that. Okay. And she is very good patient. She is compliant with the inhaler, because we all know the compliance to inhaler is one of the important cause for exacerbation in asthma. And she shows the technique very well. And she does not have any hemoptysis, no weight loss at present. And her chest X-ray was reported every time as non-specific increased bronchovascular marking. So what we should think in this patient? Okay. So is this a poorly controlled asthma? How many of you agree with this? Is it a poorly controlled asthma? No. Is this a recurrent infection? Just a recurrent infection the patient is having? Or are we missing something structural in this patient? Yes, definitely. So what should be the next investigation that would change the modality or the management? Yes, definitely we have to go with the HRCT thorax. Okay. So key learning points from this patient is asthma does not cause persistent daily purulent sputum. Okay. So one thing you remember, it does not cause persistent daily purulent sputum, and recurrent infective exacerbation, which is disproportionate to asthma severity, should raise suspicion of something else, because what happens is she is very compliant to inhaler and she takes care of her asthma very well, but the recurrent infective exacerbations are very disproportionate to the asthma control. And chest X-ray may not pick up early changes of bronchiectasis. So we should not completely rely on chest X-ray for diagnosis of bronchiectasis, especially the early bronchiectasis. So HRCT thorax is required to confirm even the early changes of the bronchiectasis. So in this patient, we should not ignore it. Okay. So coming to the topic of the day, bronchiectasis. So in the medical field, we have terminologies which are very self-explanatory. We don't have to remind or have some factual memory, or we have to ratify that definition. Just you split the word bronchiectasis. Okay, so definitely we see this is a Greek word. Most of our medical terms are derived from Greek root. So what we can say here is bronchion, which means windpipe, and ectasis means stretching out. So bronchion means a windpipe and ectasis means stretching out. So the self-explanatory word tells that it is a stretching of the bronchi. Can anybody tell me who has described this bronchiectasis at the first time? Any famous individual or famous personality you guys know who has described the bronchiectasis for the first time? Okay, so it was René Laennec who has described, yes, very good, Dr. Navanil. It was René Laennec who has described this particular disease for the first time in 1800. Okay, in 18th century, that is 1819. Can anybody tell me what is the other major significant contribution from Laennec? Yes, very good, Dr. Aisha. It is stethoscope. He is the person who is behind the pride of the doctor, which we wear and go every day to our OPD, a stethoscope. And but you see the mystery or the unfortunate with the life of Laennec. Can anybody tell me how he died? What was the disease he was suffering from? It's just a history part. I just don't want to get dwell into much. So it's just an interesting part. So I wanted to share with all of you. So because we should know the history of certain prominent figures. So he died of TB and at a very young age of 45. So I remember here our late Mr. Rajesh Khanna's dialogue, Zindagi lambi nahi badi honi chahiye. So in the medical field, what we see, the medicine advances not by lifespan, but by legacy. So in a very short span of 45, he has done a lot of contribution to the medicine, which till today we are using it. So we all think that it's very early to start. No, it's not like that. So we have to start when the right time comes. So this is what about a brief history about the Laennec and the lesson we are learning from his life. Okay. So definition of this bronchiectasis, it's a chronic. So please remember, it's not an acute, it's a chronic respiratory disease, which is characterized by irreversible bronchial dilatation. Once the damage has happened, it has happened. It cannot be reversed. And it is basically HRCT based, and the patient has a chronic productive cough on symptom, and the patient will be having recurrent infective exacerbation. I'll tell you why the patient is having recurrent infective exacerbation in the pathophysiology part. So coming to the etiology, there are various etiologies which are causing bronchiectasis. So the most common globally is post-infectious, and especially in a country like India, where there is a high prevalence of tuberculosis, post-tuberculosis, because of the fibrosis, and there is a distortion of the airway and stasis of secretion. Because of that, post-tubercular remains the most common cause of bronchiectasis. Or certain individuals who have a severe childhood history of recurrent pneumonias, especially with measles, pertussis, and in adults who are suffering from necrotizing bacterial pneumonias or viral pneumonias, though they are rare, but possible etiology for causing post-infectious bronchiectasis. Coming to the second important cause is allergic bronchopulmonary aspergillosis. It is a hypersensitivity reaction to the fungus Aspergillus. Here, Aspergillus is not doing anything. It's an ubiquitous organism which is present in the normal environment. When a hypersensitive individual going to inhale this fungus, there is a hyperimmune response. And because of that, there will be a collateral or a parallel destruction of the airways that is seen in allergic bronchopulmonary aspergillosis. and certain immunodeficiency conditions like common variable immunodeficiencies or certain immunoglobulin deficiencies like IgG and IgA, which are very important in inflammatory cascade, and also in case of HIV or retroviral diseases. Certain congenital or genetic diseases which are associated with bronchiectasis, though they are rare, but they are associated. The most common in Western country, which we see, is cystic fibrosis. Again, it is a autosomal dominant condition with CFTR gene mutation. And we have congenital issues like pulmonary agenesis, sequestration, or tracheobronchomegaly. And also the connective tissue diseases like rheumatoid arthritis, Sjogren's syndrome, and SLE. So all these tend to contribute towards the etiology of the bronchiectasis. So when you see a patient of bronchiectasis, all these etiologies should run in your mind, and you should try to take a history related to these diseases. These are quite common etiologies which we see. And we have certain localized bronchiectasis, which is mainly due to endobronchial tumor causing post-obstructive stasis of secretion. Then we have a foreign body or a lymph node compression, which is externally compressing the airways, or bronchial stenosis due to the fibrosis. And sometimes this chronic aspiration due to severe GERD can also cause right-sided bronchiectasis or right-sided interstitial lung diseases. And certain environmental factors like toxic inhalation or repeated smoke exposure or severe air pollutions are also considered to be as a further causes of bronchiectasis. And very important, another aspect of the airway disease is it is causing bronchiectasis to recurrent exacerbation and recurrent inflammation. That same cycle continues in case of severe asthma or a chronic obstructive pulmonary disease. They tend to land up into bronchiectasis in a later stage of the disease. And there are infections related to chronic colonization. We all know the notorious non-tubercular mycobacteria, which is very slow growing, and it is more prone to colonize. So it can be acting as a cause or as a consequence of the bronchiectasis. And despite you do extensive evaluation, there are few patients in whom the cause remains unexplained, and those subset of patient may vary from 20 to 30, depends upon different reference articles or different books. But ideally, we take 20 to 30% of individuals, despite the extensive evaluation, they don't have any known cause for bronchiectasis. So pathogenesis is very important for bronchiectasis, because when you understand the pathogenesis, it is easy for you to treat the bronchiectasis. So in these many patients, they give a history of significant LRTI in early childhood, which I already mentioned in etiology. And most of these infections, they have a severe bronchial inflammation, and that leads to necrotizing bronchitis, and as a result of it leads to permanent dilatation. And because of this dilatation, there will be excessive mucus production, and that get stagnated, and this mucus along with the debris, they get they clog the peripheral areas, and that leads to small amount of atelectasis. So the common notorious organisms here are Haemophilus influenza and Pseudomonas aeruginosa. They have their own intrinsic factors. So they impair the normal ciliary movement, and that helps them stay inside the lung for a longer period of time rather than being cleared out. So we have a Pseudomonas aeruginosa, which is the most potent and most virulent organisms which see in bronchiectasis. I'll tell you the importance of the Pseudomonas aeruginosa in bronchiectasis. It produces a chemical called 1-hydroxyphenazine and a pigment called pyocyanin that helps it to stay inside the lung for a longer period of time. Similarly, we have Haemophilus influenza and Streptococcus pneumoniae. They also have a very high chemotactic factor, which helps it to attract the neutrophils to the bronchial lumen, and as a inflammatory cascade, it can lead to a bronchiectasis. And we should suspect, when the patient complains of foul-smelling purulent sputum production, certain anaerobic organisms are also present in the bronchiectasis. And we have a separate set of bronchiectasis, which is directly related to pulmonary tuberculosis. And since they have a predilection to involve the upper lobe, and the upper lobes are majorly affected in these, so the symptoms are more predominantly from the upper lobe. So since there is a gravity enhanced drainage, the secretions are drained. There is no stagnation or stasis of secretion. But It can also result in bronchiectasis due to two important several mechanisms. It can be post-infectious as a consequence of TB bronchitis, or post-obstructive in case of bronchial stenosis or lymphadenitis causing compression from the external side of the lumen. So these patients tend to have very little or no amount of sputum, but they are presenting with the hemoptysis. And this is what we call it as bronchiectasis sicca. Sicca means dry. So they have a very minimal sputum, but majority of the hemoptysis, because they don't tend to present in the early stage, they get destroyed, and then the chances when the bronchial vessels are involved, there will be chances of massive hemoptysis. So this we are going to term it as bronchiectasis sicca. So coming to a very important vicious cycle, which few of you has already mentioned in the beginning of the webinar. This cycle is very important because for the management of bronchiectasis, we have to break this cycle. This cycle is keep on continuing inside the bronchiectatic lung. So how it starts is with the help of an initial trigger. You can see here any infection or a mucus ciliary defect that leads to impaired mucociliary clearance or the hydration of the bronchi. So what happens because of that? This stagnation of secretion itself is a nidus for infection. So the patient will have recurrent infection with certain bacteria like Pseudomonas, tuberculosis, non-tubercular mycobacteria, or Staph aureus or Haemophilus influenza. And these colonizations, they also have certain biofilm formation, which helps them to tolerate the antibiotics, tolerate the body's immune response, and they can persist for a longer period of time. And because of that fighting of infection, inflammation, the relentless fighting and the neutrophil influx and the cytokine release, they all lead to damage of the adjacent structure. So there is a destruction of the bronchi, dilatation or tissue destruction. So this cycle keeps on continuing till there is a stagnation of secretion and the presence of organism. So this is a Colles vicious cycle or vicious vortex, what we call. So it is mainly neutrophil driven inflammation. Okay, so this is a bookish theory, that is theories of bronchiectasis, which we used to study during our postgraduate time: atelectasis theory, traction theory, and pressure of secretion theory, which is of not much use in the recent practice. So coming to the second case, I hope you all are ready. Okay, so in second case, what we see here is a 35-year-old man, again a case of bronchial asthma. He has bronchial asthma since childhood. He has come to us with increasing wheeze over past 1 year, and he also had a recurrent exacerbation despite appropriate inhaler therapy. So you can see here he was very much adherent and compliant to the inhaler therapy, but despite of that, there is a recurrent exacerbation. He already has received 3 courses of oral steroid in the last 6 months. So already 3 courses of oral steroid is already done for this patient. But despite that, he has a persistent cough with sputum production. So he also tells that his previous chest x-rays show some transient opacities that get later resolved when they are treated with steroid. So whenever he goes to any doctor, he gets an x-ray and there is an opacity, he gets treated with antibiotic, steroid and all, and when the x-ray is repeated, it will be resolved. So on examination of this patient, there was bilateral wheeze, and when we performed the blood investigation, the significant finding was peripheral eosinophilia. Other investigations were within normal limit. Then we asked for an HRCT, which showed predominant central bronchiectasis. So is this just a severe asthma, what we are seeing in this patient? No. Okay. Or is this just an infective bronchiectasis? How many of you will tell, is this an infective bronchiectasis? Okay, most of you will tell infective bronchiectasis. Now let me come to the last question. Or are we missing any allergic component? Now your answer will change or it remains S. Okay, so how do you differentiate now whether it is an infective or an allergic component? Can anybody? Yeah, that's what we don't know. How to confirm? Very good. Twinkle, Dr. Twinkle has answered. Very good. After IgE level, anything else? Yes, one is IgE level. AAC is already done. AAC shows eosinophilia, I already mentioned. blood test shows eosinophilia. Serum Ig level is one investigation which we need to send. Definitely yes. Anything else? Sputum color. How do you, what do you assess with sputum color? What investigation we have to send other than IgE? If you are suspecting allergic component in etiology, I have told you one etiology. So we have to send total IgE and aspergillus specific IgE. Okay. So aspergillus specific IgE. Okay. So these two things needs to be sent, and these two were sent, and they were found to be on the higher side. Okay. So the diagnosis was, can anybody tell if these two are on higher side, what will be the diagnosis? What is the etiology of bronchiectasis in this patient? If these two are on higher side, what could be the possibility in an asthmatic patient who is having a central bronchiectasis? Serum IgE level, total IgE, and aspergillus specific IgE are on higher side. Pneumonia? No. It is allergic bronchopulmonary aspergillosis. Okay, so aspergillus is not doing anything here. Since he is an asthmatic, he is hypersensitive. Just when he inhaled the aspergillus, there is an hypersensitivity response. That's why we see total IgE, aspergillus specific IgE, AEC are on elevated on the higher side. If there was an infection, we can see he has a fever, or he has a chest pain, or there will be other radiological findings on the HRCT, or his CRP or other infective markers would have been elevated. So in this case, they were all negative, and the allergic component was on higher side. So it was diagnosed to be allergic bronchopulmonary aspergillosis. So from this case, what we learn is, any patient who are having asthma and on HRCT, you find it as a central bronchiectasis, is always a red flag. You should always think one of the DD for this is allergic bronchopulmonary aspergillosis. And asthmatics, they tend to have eosinophilia. In such patients, you should not ignore eosinophilia. Don't think that it is because of asthma and just ignore it. No. And recurrent infiltrates, what the patient has mentioned, fleeting opacities, they are very classic. They are present at particular time, and after giving course of steroid, they will disappear. And elevated total IgE or aspergillus specific IgE is must, and they are helping to confirm the diagnosis according to ISHAM criteria. ISHAM criteria is used for diagnosis of ABPA, and it is diagnosed in early treatment, then you can prevent the progression to fibrosis. So not all bronchiectasis in asthma are infective. Some are immunological. So always keep these things in mind. Okay. Because don't see any asthmatic patient post airway disease. Yes, there are certain findings which help you to substantiate it can be post airway, and there are certain findings and investigation which help you substantiate it is due to immunological response and not due to infective part. So that was the learning point from this case. Okay. So this is again one more important chart which most of you will be like, it is useful if you are writing some competitive exam, or sometimes we see certain syndromes and they are coming with the bronchiectasis. So we have, first important is Carter-Jenner syndrome, which is a triad of primary ciliary dyskinesia and situs inversus, and along with that infertility. We have Marfan syndrome, which is a type of connective tissue disorder because of the airway weakness, but it's a rare association. And we have Young syndrome. Again, we have obstructive agiospermia with the bronchiectasis, but here the ciliary functions is normal. And we have something called Lady Windermere syndrome, and it is commonly seen in non-tubercular mycobacteria, that is Mycobacterium avium complex, and especially in elderly women who are having voluntary cough suppression, and they tend to swallow the sputum. So they are having middle lobe bronchiectasis. So already I have mentioned in the etiology, this NTM can be a cause or as a consequence. And when you see a middle lobe bronchiectasis on bilateral side, always think of non-tubercular mycobacteria. Do you have yellow nail syndrome, which is yellow nails plus lymphedema plus pleural effusion and bronchiectasis. And we have certain congenital like Munier-Kun, where we have tracheobronchomegaly that leads to recurrent infection and bronchiectasis. And we have William Campbell, which is defective bronchial cartilage causing airway collapse and bronchiectasis. And we have a disease which is having lung skin involvement, that is lung cyst, which is leading to spontaneous pneumothorax and skin fibrofolliculoma, and also it causes bronchiectasis. Okay. So this is again one important slide which you have to remember, and these features you have to remember in certain syndromes where you can connect all these points and you can derive a diagnosis. So coming to clinical feature or clinical picture of this bronchiectasis, they tend to have a persistent cough and mucopurulent sputum. This is a very important mucopurulent sputum, and it is more in the morning. It is more in the morning because overnight they will be having stasis of secretion, and early morning when they get up, either before brushing or after brushing, they tend to expectorate a lot of amount of sputum. So that one thing you have to ask in a history to the patient when you're suspecting bronchiectasis. Always ask early morning, do have a copious amount, a large amount of mucopurulent sputum expectorating early in the morning. And again, this amount and the consistency and the smell and all, we have to take a proper history. So during the flare up of infection, there is sudden increase in the volume of the sputum or purulence of the sputum, and if it is due to anaerobic, there will be foul smell along with the other constitutional symptoms and fever. And one more important finding, what you see in bronchiectasis is postural change. Okay, it may be because of the displacement of the secretion, and that will cause irritation of the normal lung, and that will cause a postural change, and cough and sputum production will be triggered. So patient will tell on a particular side when he lies down, the cough will be on higher side. So this is also one of the important clinical feature which we have to ask in patients of bronchiectasis. As I already mentioned, hemoptysis is classically associated with bronchiectasis, and they are mainly from the bronchial artery. This is our worrying part, because any hemoptysis arising from the bronchial circulation, which is almost equivalent to systemic circulation, they tend to have massive hemoptysis, and the massive hemoptysis can lead to asphyxiation, and that leads to death. So always remember, massive hemoptysis is one of the differential diagnoses of bronchiectasis. And in the beginning, somebody has mentioned about the dyspnea. Yes, chronic dyspnea can also occur, but it is a very late symptom. And it is mainly because of the destruction and fibrosis. Okay, but in exacerbation, it can be due to superimposed LRTI, which is exacerbating their underlying airway disease like asthma or COPD. So also we have some coexisting symptoms like fatigue, malaise, or anorexia can also be there if there is an underlying tuberculosis. So coming to the signs, in mild cases, there is no abnormal physical sign you find in bronchiectasis. That's why it tend to be missed in OPD. And clubbing, yes, clubbing can be seen in bronchiectasis. One of the cause for respiratory cause for clubbing is bronchiectasis, and it's a feature of a chronic extensive disease which is leading to hypoxia. And very important finding on auscultation is early or mid inspiratory coarse. Initially, they used to describe it as a leathery, coarse crepitations you can hear, which is localized to the area where the lung fields are involved. And there are associated findings of other underlying diseases like connective tissue disease if they are suspecting for bronchiectasis. Then we have for rheumatoid arthritis, early morning joint stiffness, joint pain or arthritis, SLE, we have malar rash. So different underlying diseases will have an associated finding. So these are the signs what we find in cases of bronchiectasis. So coming to the diagnosis, chest X-ray is not very sensitive for diagnosis of bronchiectasis. It is unreliable because of its low sensitivity, and it is still useful as screening tool. What I feel is for severe diseases, and it can help you to go HRCT immediately or later. But definitely, if you have a strong clinical suspicion and a strong history which is going in favor of bronchiectasis, definitely it is worth to go for HRCT, because early diagnosis and early treatment can help you slow down the progression. So coming to the X-ray findings, we have certain findings like ring shadows. Ring shadows are usually the dilated thickened bronchi. So this is a dilated thickened bronchi which is seen as an end-on. Okay, so you can see this as an end-on if it is a lung. Okay, so you can see this dilated thickened bronchi as an end-on appearance. Similarly, we have parallel lines. These thickened bronchi, when you see end-on, they look like a ring shadow. But when you see as a side-on, okay, they look like a parallel line. Okay, when you see as an end-on, they look like a ring shadows. But when you see the same bronchi on the side-on, okay, so it looks like a parallel line. They are dilated bronchi. And there is something called finger in glove, which is very characteristic for mucus plugging. And these mucus will plug into the airway, and that looks like a finger in glove appearance. I'll show you the images in subsequent slide. So these dilated bronchi, they contain secretion and they appear as solid tubular opacities. They are very characteristic for mucus plugging, and that is commonly seen in allergic bronchopulmonary aspergillosis. So coming to HRCT, the main features of HRCT are, the first and foremost important is signet ring, where the diameter of the bronchus and the accompanying pulmonary artery is measured, and normally the pulmonary artery is larger than the adjacent bronchus. But in case of bronchiectasis, since they dilate, the diameter of the bronchus will be larger than the adjacent pulmonary artery, and the ratio can go beyond 1. Certain books, they tell 1.5, 1.5 can be taken as a cutoff, and absent bronchial tapering even on the outer 1/3 of the lung. So normally what happens when you take the lung CT, okay, so at the peripheral 1/3, it has to taper. The bronchus has to taper. But in case of bronchiectasis, because of the dilatation and destruction, the bronchus will remain parallel. Okay, so tapering is absent in the outer 1/3, and along with that, there will be a bronchial wall thickening. Okay, and there will be a bronchial wall thickening. Okay. So this is about the broncho-arterial ratio. So you can see here images. Okay, this is a bronchus and this is a small artery. Okay, normally the ratio is 0.7. You can see the artery is small, slight bigger is the artery, and the bronchus is small. And when the ratio becomes 1, you can see this is a bronchus. Okay, this is a bronchus. This becomes dilated, and when it becomes beyond 1.5, then it is more dilated. Okay, so it looks like a signet ring. Okay, you can see multiple signet ring sign here. Okay, and there is no other evidence of any other bronchiectasis. So these are all early changes you can see here. Okay, so this is an X-ray of a patient. Okay, you can see left-sided cystic shadows. Okay, cystic shadows. It's a completely destroyed lung on the left side. This patient had multiple past history of tuberculosis. So we thought it is due to post-TB sequelae. Okay, left side, and you can see the trachea. You can delineate the trachea here. It is shifted towards the left side. So there is evidence of volume loss, and you can see the cardiac silhouette is also shifted towards the left side. Okay, so it is a complete case of left-sided volume loss, could be due to fibrosis and cystic bronchiectasis. Okay, and when you see the CT of the patients, you can see the cystic images, cystic bronchiectasis. It is one of the most severe form of bronchiectasis. All the cysts are there, and this gives a typical bunch of grape appearance. What we tell, a bunch of grape appearance. So you can see this gives a bunch of grape appearance. Okay, so this is a CT of cystic bronchiectasis, and some cysts, they have this fluid level. Okay, that means there is suggestive of infection. This suggestive of infection. Okay, and you can see some small signet ring here. Okay, these are the arteries adjacent to the bronchus. Okay, so as I already mentioned, you can see this is an image of finger in glove. Okay, these are all dilated bronchi, yellow color, and you can see these finger in glove. These are mucus plug which are present in the dilated bronchi. Okay, so when you wear a glove and see finger in glove appearance, so it's similar to that. Okay, so these are all bronchi or dilated bronchi, which these are dilated bronchi when they are filled with the mucus plug. It is seen in that situation. So mucus plugging is one of the cause for this finger in glove appearance. So coming to the microbiology, which is very important because these organisms should be known for a targeted antibiotic therapy. So Haemophilus influenza was found to be most commonly isolated, followed by Streptococcus pneumoniae. But we have also Pseudomonas aeruginosa and Klebsiella. But these are into a certain subset of patients who are diabetics, elderly, or who are already used prolonged antibiotic. And in the beginning of my webinar, I have mentioned Pseudomonas has an important relation with the bronchiectasis. When you see Pseudomonas in a bronchiectatic sputum, it is a worse prognosis marker because it has a very high tendency of persisting inside the lung with the help of formation of biofilm, which helps it to persist and have antibiotic resistance. So Pseudomonas presence in the sputum of a bronchiectatic patient is considered to be as a worse prognosis marker. So always you have to send sputum before initiation of antibiotic during exacerbation. So we tend to not to follow this line, because the moment the patient comes in exacerbation, we directly give him stat medications and start him on antibiotic. And when next day we go for round, we will be sending him the sputum for culture. That should not be done. Immediately when the patient comes, once the patient is stabilized, you have to send the sputum for culture, and followed by which you have to start an antibiotic. So what ERS suggests is routine sputum culture should be done at the baseline and also during the exacerbation, so that we should know whether it is the same organism causing exacerbation or it is a new organism causing exacerbation. Okay. So in bronchiectasis, it is incomplete without discussing this one word, that is chronic colonization. So chronic colonization is isolation of the same pathogen in more than 2 sputum cultures, okay, which is taken at least 3 months apart. This is a ideal definition. Okay, in 1 year, 3 months apart, 2 sputum cultures from a bronchiectatic patient shows same pathogen growth. So that is a meaning of chronic colonization. And why it is important in bronchiectasis is because it is associated with increased exacerbation. That means that organism is having a tendency to persist there for a longer time, and it helps decline the lung function in a very faster rate. And because of this increased exacerbation, there will be higher hospitalization, and all of this will contribute to increased mortality. So that is why the reason the chronic colonization has been defined in a bronchiectasis patient. So this is the significance of having chronic colonization. So when you see first isolation of Pseudomonas, you always have an attempt to eradicate. Don't just take it lightly. When you see a first isolation of Pseudomonas organism in a bronchiectatic patient, try to eradicate it. Otherwise, the prognosis is worst. If it is persistent, then it is called chronic colonization. If it is a single random growth, then don't label it as a chronic. Okay, if it is first and single random growth, don't label it as a chronic. If it is more than 2 sputum culture taken at least 3 months apart within a 1 year of span, then it is considered to be as a chronic colonization. Okay. We have some scoring system which helps you predict the mortality. Ideally, this scoring has to be done in any OPD or IPD patient of bronchiectasis, where the terminology called FACET score, and F stands for FEV1 when we perform spirometry, the percentage predicted, and we have A for age, C for chronic Pseudomonas aeruginosa colonization. I told you, Pseudomonas aeruginosa colonization, it matters a lot in case of bronchiectasis. And extension, when you do HRCT, we have number of lobes involved, and D for dyspnea, that is a symptomatology. So you can see FEV1 of less than 50, more than 50, age of 70, Pseudomonas, if it is there, it is considered to be as a 1, and extension, if it is beyond 2 lobe, it is considered as 1, and higher the grade of MMRC, it is 1 number. So we divide the severity or the mortality, mild, moderate, and severe. So it helps you predict the 5-year mortality in case of bronchiectasis. After that, there was an update in this score, because the one factor which we missed in this score, it has contributed more towards the mortality, and that factor was exacerbation. So how many exacerbation the patient is having in a year, or how many hospitalization due to exacerbation was added, and that it became a E-FACET score. So this has increased the predictability of this score by adding just an exacerbation history. So if it is more than 2 per year or 1, which is leading to hospitalization, again, it is an E-FACET score, which is very important for predicting the 5-year mortality. Okay. Other than that, we have one more very comprehensive, elaborative scoring, which is called Bronchiectasis Severity Index. I don't want to go in much detail. Just I will help you differentiate the BSI and FACET scoring. This has a body mass index, and this takes into consideration of the chronic colonization of the Pseudomonas aeruginosa. Okay, so this has a body mass index, which we don't see in FACET or E-FACET, and it is a better predictor of hospitalization. It's a better predictor of hospitalization. So when we compare the E-FACET, which is the latest of FACET score, versus the bronchiectasis severity index, what we see here is BMI is an extra thing which helps in bronchiectasis severity index. So it also includes about the previous hospitalization, and this is considered to be as a more prognostically detailed index. Okay, but ideally feasible severity index is FACET or E-FACET. If you do E-FACET also, that is more than enough. You don't have to sit and do for bronchiectasis severity index. So FACET predicts 5-year mortality, And when you add an exacerbation history, it can also predict the exacerbation risk. But the most comprehensive risk stratification tool is the BSI, which helps in predicting hospitalization better than FACET. But it is little more cumbersome. You have to take a height, weight to calculate the body mass index. Okay. So when we come across the bronchiectasis management part, so this is a pyramid of the bronchiectasis management part. And when you go from below to up, we are going to go for an escalation therapy. When the disease goes from mild to moderate, we are going to escalate it into upper direction. So the foundation of treatment, it is included for all the patients, mild, moderate, severe. The very important foundation is airway clearance therapy, because when you clear the airways, then only you are going to break that vicious cycle. Okay, the stasis of secretion that should be inhibited, that should be avoided in order to prevent the infection. So airway clearance therapy is given for all the patients, and you should also vaccinate the individuals who are having bronchiectasis in order to avoid recurrent infections causing further damage. And very important aspect is identify and treat the underlying cause. Don't just leave bronchiectasis patient by giving the airway clearance therapy, vaccination, and long-term or a short-term antibiotic. Try to find out the etiology. Try to find out the causative factor. If you treat the causative factor, the progression can be reduced, the progression can be slowed down. Okay. And at the time of active infection, obviously you have to control active infection either with the help of culture-guided antibiotics or a treatment of acute exacerbation, which I'll be discussing in a subsequent slide. And in the first growth of Pseudomonas aeruginosa, always try to eradicate. I'll tell you how to have a Pseudomonas aeruginosa strategy. Okay. And to prevent the exacerbation, like we have a long-term macrolide, which is given in selected patients, or inhaled antibiotics can be given in patients who are having chronic Pseudomonas colonization. And in advanced or refractory disease, we have one important complication, which is hemoptysis. And regarding the hemoptysis, I have already taken a webinar, which you can go and watch in the YouTube channel of Mediversal Academy, how to deal with hemoptysis, massive hemoptysis, and I have taken all the aspects of hemoptysis, how to manage with the bronchoscopy, how to manage with the medications. So that webinar will help you to understand the management of massive hemoptysis in a bronchiectasis patient. Okay. So coming to airway clearance, it is mandatory, and according to the guidelines, it is strong recommendation for all the patients. So how to do that? We have to go for a breathing technique, huff and puff technique. Then we can go for postural drainage with the help of hands or any other oscillatory positive expiratory devices, or pulmonary rehabilitation in the form of deep breathing exercise, limb exercise if the patient is having dyspnea. So airway clearance techniques are very, very important. And vaccination, again, we have common influenza, pneumococcal, and COVID that can be given according to the policy and guidelines. So stagnation of secretion is a very important part of vicious cycle, and it requires regular mucus clearance technique. So we have a chest percussion and postural drainage. These are the techniques. They don't require any special device, but at the same time, they are little cumbersome and uncomfortable because each lobe has a different type of drainage and percussion. So that's why the patient will not be able to adhere to the treatment for a longer period of time. But we have certain devices which helps to make the patient to expectorate. So these mechanical devices have been designed in order to have a convenient and effective way of giving airway clearance therapy. In that we have ultrasonic vibration devices or positive expiratory device, and there are some vests which helps you to vibrate and cause the movement of secretion, and the patient will start coughing and he will be able to expectorate all the sputum. So, and there are certain devices which also helps the patient to make airway clearance. And always search and treat the underlying cause. For example, if it is ABPA, the treatment remains different because we have to start treating with oral steroid. And if needed in refractory case or severe cases, we have to go for antifungal. If it is due to immunodeficiencies or some autoimmune diseases, or it can be due to obstruction, can be localized obstruction. So all these things can be given in case of search and treat the underlying cause. Pseudomonas strategy, I have already told you, Pseudomonas is very important in case of bronchiectasis. You should always have an attempt to eradicate this Pseudomonas from the lungs of the bronchiectatic patient. So in severe cases, we can go for IV anti-pseudomonal antibiotics, like we have piperacillin, tazobactam, meropenem, carbapenem family is there, or we have fluoroquinolone family, or we have higher generation cephalosporins. And we have certain inhaled antibiotic which are selectively targeting towards the Pseudomonas. So as I already mentioned, chronic colonization, which is more than or equal to 2 cultures, 3 months apart in a span of 1 year, because it is having more exacerbation and higher mortality. So management of this is long-term inhaled antibiotic, and in certain individuals, we can also consider macrolides like azithromycin if it is not contraindicated. I'll tell you what are the prerequisites to start macrolide for a longer period of time. We should have certain prerequisites. We cannot just give macrolide for a longer period of time simply like that. Okay. So coming to third case, one more case we are going to discuss here. I think you guys are ready. Okay, so here 58-year-old woman with established non-cystic fibrosis bronchiectasis, because we define it as cystic fibrosis, non-cystic fibrosis bronchiectasis. She came as a routine follow-up. She also gives history of daily mucopurulent sputum, which is chronic. And in the last 1 year, she has 4 exacerbation. And we can see 2 hospital admissions. 2 hospital admissions are there. And there is increasing breathlessness on exertion. Increasing breathlessness on exertion. But currently, when the patient came to you for follow-up, she does not have any fever, no increase in sputum quantity, or no new chest pain. Her blood investigations, you can see CRP is in normal, eosinophil count is normal. Sputum culture, again, it shows Pseudomonas aeruginosa. And when you review her records, the same organism was grown 2 months before. But the present chest X-ray shows no fresh new infiltrate. It is same like how old X-ray is. So is this an acute infecto-exacerbation? Is this an acute infecto-exacerbation? Okay. Or is it a chronic colonization? Is it a chronic colonization? Yes. So how we can substantiate that finding is there is no clinical deterioration. Patient does not give any fresh complaint. The CRP is not rise. No neurological change. But the same pathogen is grown more than 2 times within 3 months. That suggests there is a colonization and not acute infection. So what will you do next? What will you do next for this patient? How do we tell it is a severe, mild, moderate? How do we tell? Yes. So if there is a first isolation of the organism, we have to attempt eradication. If there is repeated isolation, then it is called chronic colonization. Then we have to treat the patient with, yes. So we can go for inhaled antibiotic or long-term macrolides, and we have to optimize the airway clearance. And before starting the macrolide, we have to always rule out the non-tubercular mycobacterial infection, because chronic Pseudomonas is very having worse prognosis. Okay, so colonization can be silent, but prognostically it is very significant. So what we think is right now, the patient is not having any symptom. At present, the patient is completely fine, but inside it is causing destruction. The patient prognostically will do very bad. So prognostically it is very significant. That is what the key learning point from this case scenario. So long-term preventive strategy as per the guideline, it is given only in patients who are having more than 3 exacerbation per year or who are having frequent hospitalization. So we have 2 important things we can use. One is macrolide, which helps in reducing the exacerbation like azithromycin. And before starting, we have to rule out non-tubercular mycobacteria, and we should get a baseline ECG for QT prolongation. And we should also go for an hearing check. So these are the prerequisites to be done before starting a long-term macrolide therapy. And we have inhaled antibiotics. For example, inhaled colistin or tobramycin can be used, especially in patients who are having chronic Pseudomonas or frequent exacerbation. So we can give up to 15 days or 1 month or 2 months, we can give inhaled antibiotic for a period of time. Okay. So coming to acute exacerbation management, in acute exacerbation management, the definition of acute exacerbation is, again, there is a worsening of cough and sputum is showing volume or purulence, and there are systemic symptoms. So the treatment principle here is, yes, before you start the antibiotics and the sputum culture, and for acute exacerbation of bronchiectasis, the antibiotic duration is around 10 to 14 days. Don't just stop at 5 to 7 days. Give them for 10 to 14 days. They tend to have a chronic colonization, and always target the previous microbiology. If it is Pseudomonas, always give for a longer duration of time. Don't just give 5 days antibiotic course, and don't give routine steroid unless and until you are very much confirmed it is an immunological reaction, not an infective reaction. And don't ever start empirically anti-tubercular treatment if you don't have any microbiological or radiological evidence of tuberculosis in a patient. So hemoptysis, which I already told you, the source of hemoptysis in this bronchiectasis patient is bronchial artery, which is systemic circulation, and they tend to have massive hemoptysis. And management wise, you have to stabilize the patient first, airway stabilization, breathing and circulation. And if there is a time, go for CT angiography. And if possible, bronchial artery embolization, that will help you get some time for bridging to go for a permanent surgery, and surgery is given only in selected cases with selected indications. It is not done in all the patients of bronchiectasis. I already mentioned for detailed management of hemoptysis, already there's a webinar on YouTube channel of Mediversal Academy, which is done by me. You can go through it again. So these are certain indications of surgery in bronchiectasis. The first is failure of optimized medical therapy for 1 year. If patient is having severe or frequent exacerbation, or the patient is having complications like empyema or lung abscess, or the lesion is localized, and to avoid sepsis and extensive damage of the lung, or it is distal to a tumor, or there is a recurrent or refractory massive hemoptysis, then you can go for surgery. But again, the clinical, the performance status of the patient is evaluated. It's not that just the patient is having severe exacerbation, put him to the surgery. No, patient has to be physically fit. He has to be having good performance status. Then only the patient can undergo surgery. So what not to be done in a bronchiectatic patient? Just routinely start inhaled corticosteroid. No, don't do that unless and until there's an overlap of asthma, there's a evidence of immunological involvement. Unless and until you don't have a strong evidence, clinical, radiological, or a blood investigation, don't just routinely start ICS. And don't just go for dual bronchodilator therapy without any obstruction. If you find it is post-airway disease, post-obstructive bronchiectasis, like post-COPD bronchiectasis or post-asthma bronchiectasis, yes, there is an evidence of that, then only you start a dual bronchodilator. Otherwise, don't add on a dual bronchodilator. And don't give a long-term oral steroid, again, unless and until you have a evidence of ABPA. Don't give long-term oral steroid. And empirically, anti-TB should not be started in a bronchiectatic patient, because rather than causing improvement, it will cause more harm because of the side effect and also the resource depletion. And also the patient will not take the medication for a complete period of time. So don't even start empirical tuberculosis unless and until you have a confirmed diagnosis of tuberculosis. Then we should have a phenotype-based approach. Instead of one treatment for all, you should identify the types of bronchiectatic patients. Some patients are frequent exacerbator. You should find out what is the cause of their frequent exacerbator. Some patients will have Pseudomonas colonized. You tailor it to the long-term strategy and Pseudomonas eradication. Some patients are ABP associated. Yes, you can give steroid and reduce that. And you can also have autoimmune associated. Autoimmune is again, you have to identify which autoimmune diseases are involved and treat that autoimmune diseases. So you have to tailor therapy accordingly. So don't just make a label of bronchiectasis and give the patient or whatever treatment available. Don't do like that. Tailor the therapy, make a phenotype based approach, and find out the cause. Okay, find out the etiology, whether it is an infective, immunological, or recurrent infection, or an airway disease which is causing exacerbation. So all these things have to be kept in mind when you have a bronchiectasis patient. So coming to the overall of the treatment aspect. So first is you have to confirm the diagnosis by chronic productive cough, recurrent exacerbation, and HRCT, irreversible bronchial dilatation. So then you should go for a baseline workup, which can be post-infectious, post-TB, ABPA, immunodeficiency, or autoimmune diseases, or certain congenital like cystic fibrosis, primary ciliary dyskinesia. If you find a cause, treat the cause if it is identified. Then assessment of severity and risk. Again, we have to get a FACET score or E-FACET score or BSI score with a Pseudomonas colonization, FEV1 from spirometry, and what is the exacerbation frequency. If there is an acute exacerbation, give an antibiotic course of 10 to 14 days. If it is not, then continue the chronic care of airway clearance. And if there is Pseudomonas eradication or chronic colonization needs to be stopped. And core management for all patients is airway clearance, rehabilitation, and vaccination. These three has to be done from mild to severe cases. If there is a frequent exacerbator, you can go for long-term macrolide after excluding non-tuberculous mycobacteria, or you have to check for a QT interval at a regular period of time. Pseudomonas strategy, first isolation, always eradicate with the inhaled antibiotic or macrolide. If it is chronic colonization, you can give for a longer period of time. Complication, one of the major life-threatening complication in bronchiectasis is massive hemoptysis, where bronchial artery embolization can play a important role. Okay, so it can play an important role in managing the hemoptysis for a shorter period of time. So complications of these bronchiectasis is a suppurative lung disease. So it can lead to suppuration of the lung and extensive damage, and it can spill into the blood, leading to sepsis. And that blood will take this sepsis to different organ, leading to metastatic abscess. And because of the hypoxia, there is a load on the right heart, and because of that, there will be right heart distortion and dilatation that calls cor pulmonale. And massive hemoptysis is one of the important and life-threatening. I'm telling you, any patient of massive hemoptysis, always try to rule out bronchiectasis. Always try to rule out bronchiectasis. And pulmonary hypertension and cor pulmonale can be late features. And respiratory failure is again one of the life-threatening complication. Patient comes to the casualty with respiratory failure and one of the cause of death in bronchiectasis. So coming to the last case of today's webinar, let us see how you guys will deal with this case. A 63-year-old woman, again, non-cystic fibrosis bronchiectasis, presents for follow-up. She's clinically stable. Again, the blood investigation, the infective markers are normal, but she gives history of daily purulent sputum. She has 5 exacerbation in the past year and 1 hospital admission. FEV1 was 48%, and she has a dyspnea of grade 2 MMRC. Okay. So sputum culture, we'll see last 6 months, they show 2 isolates of Pseudomonas aeruginosa, but there is no non-tuberculous mycobacteria. It is also sent. She is currently on airway clearance therapy, and she was given a course of antibiotic during exacerbation. Okay. So how do you assess the severity? We have scoring. So let us assess the severity. Facet component, FEV1 is less than 50, yes, 2 point. Age of more than 70, no. Chronic Pseudomonas colonization, yes, it is 1. Radiological extension, yes, she has radiological extension of 2 lobe involvement, then it is 1. Dyspnea, again, more than 2, 1 point. So total of 5 point. So 5 point, it belongs to severe bronchiectasis. So according to the scoring, she is severe bronchiectasis, but at present, she is clinically stable. We'll do for E-facet. E-facet shows again more than 2 exacerbation per year is there. So again, 1 additional point. So total of 6. So 6 is also going into a severe category. So according to the scoring, she has a severe category. Okay. According to the scoring, she has a severe category, but clinically she is stable at present. So risk stratification shows severe disease. So will you manage with an episodic antibiotic, or you can go for a long-term management? Can go for a long-term management. Because right now she does not have any symptom. But when you assess the severity score, it is belonging to severe stage. So better to go for a long-term antibiotic management. Okay. So in this case, what we have to learn is it's a severe bronchiectasis, and she is a frequent exacerbator with a chronic Pseudomonas colonization. So escalation is you have to go for inhaled pseudomonal antibiotic, and you have to consider long-term macrolide also. And you have to again improve the airway clearance technique. You should see whether she's doing it correct and if she's adherent to that, and pulmonary rehabilitation. And you should have a close follow-up with this patient, because prognostically she might go bad. So you can see here the risk scoring, it prevents us from under treatment. If you just see her clinically and send her back, it's an under treatment. If you assess a risk, yes. So we have to, yes, that's what I'm telling you. Risk scoring prevents under treatment. Right now, she may not have any symptoms clinically, but she has all the factors that may cause her prognosis worsen. Okay, she has a chronic colonization, she is a frequent exacerbator, she is a severe bronchiectasis. So right now, she may not have any symptom, but she will develop and she will progress very badly. That's why we are going to assess the severity, and that severity scoring converts the clinical impression into objective decision making. That is why I am going to tell you, just don't believe what you see. You have to assess, you have to score the severity, and then you have to take a treatment action plan. Because bronchiectasis, as I already told you, it does not begin with bleeding. Okay, so when the patient comes to you With hemoptysis, that means the patient is already in the later stage. So it does not begin with the bleeding at the first go. It is always begin with the daily sputum, chronic cough, recurrent exacerbation. Okay, and it does not progress overnight. Okay, it is a silent disease which is keep on happening. Even the patient is clinically stable, it is a silent disease. Okay, because of that stasis of secretion and organism doesn't sit idly there. Okay, it keeps on destroying, Okay, so it does not progress overnight, it progresses silently, and early recognition can change the trajectory. The decline will be reduced when you diagnose it early and give a effective management, even though the clinically patient is not having symptom, and early intervention which prevents the destruction of the disease. So structural disease requires structural thinking. It is not just a simple thinking. If it is a structural disease, you should always have a structural thinking of multiple factors in your mind when you see a bronchiectasis patient. So I want you all to have a multiple factors in your mind when you see a bronchiectasis patient, even though it is a mild, moderate, or severe. Try to find out the diagnosis, try to find out the cause, because early recognition can change the trajectory and the quality of life and the prognosis of the patient. You may save the patient because from becoming a chronic colonization with the Pseudomonas aeruginosa if you find it in an early stage and give an appropriate treatment. So depending on our Lennox philosophy, who have invented stethoscope, the ear is a more faithful instrument than the eye in a chest disease, because before you get an X-ray, on auscultation, you might get a crepitation. Then yes, you have to be more confident with the bronchiectasis, not just with the bronchiectasis. When you auscultate, you get a lot of finding before you order an X-ray and see it from your eyes. So always you always believe on your ear. That's why we have a stethoscope. So this is a disclaimer and this is a feedback. Okay, so any questions? It's open.
Thank you, doctor. Thank you for the session. The Q&A session is open now. Please drop your questions on the chat box. The doctor will answer your question. Meanwhile, you can scan the QR code to give us the feedback. If not, I will also post the link for the certification. You can submit your form through the link. Okay. Dr. Twinkle, you can unmute yourself now and talk.
Good evening, Dr. Sohail. Good evening, all.
Yeah, good evening.
So I just want to discuss with you that one of the patient was already diagnosed with the bronchiectasis and came with superadded tubercle lung TB. Whether we can use a low dose of steroid to control the bronchiectasis progress in on superadded TB infection.
But why do you want to use steroid to control bronchiectasis? You can start with the anti-tubercular treatment and you can go ahead with the anti-pseudomonal if the patient has a colonization with pseudomonas. I think you can observe with that. If at all there is a evidence that there is an inflammation which is causing fibrosis or stenosis, then definitely we can give a low dose steroid under the cover of antibiotic and ATT, but not alone. But first we have to deal with the anti-tubercular treatment and the anti-pseudomonal agents.
Thank you, sir. Thank you so much.
Thank you. No problem. It's a very good question. Thank you.
Doctor, we have one more question. How to differentiate diagnosis between ILD and bronchitis?
See, ILD has a different picture and bronchiectasis has a different picture. ILD predominantly presents with dry cough. Okay, patient will start with dry cough. In bronchiectasis, there is a purulent sputum. Okay, so bronchiectasis patient always they have sputum. In ILD, if you take a proper early history, they always start with a dry cough. And again, when you go on taking history, ILD has some exposure history, or ILD has, you can see 6-minute walk test. If you take, there will be desaturation. DLCO, if you perform, there will be early finding of reduction in DLCO. In bronchiectasis, you won't find such things because dyspnea occurs in a very late period of time. ILD has mainly dry cough and they have a strong exposure history or smoking exposure. But bronchiectasis, on the other hand, is completely opposite, which will be presented with the purulent sputum.
Thank you, doctor. Um, Dr. Solanki says thank you, sir, for
Thank you.
clarifying.
Thank you, Solanki. It's a very good question.
Any more questions you can drop in the chat box. Doctor is here to answer your questions.
Good evening, sir. Being working in the ICU, facing a very common problem with resistant pseudomonal infection. So, what kind of inhalational antibiotic like colistin and the tobramycin will help to a good lung penetration?
Yes, definitely. What you have mentioned is very true. In ICU setup, we do have a drug resistant pathogens, especially Pseudomonas or some gram-negative organisms. And yes, definitely these inhaled antibiotics will work. Okay. And before you go to that, you should get a culture and sensitivity pattern. That's why what you have to do is either if the patient is intubated, you can get an ET tube culture, or with the help of bronchoscope, BAL lavage can be sent for culture, and you try to get a culture sensitivity report, and according to that you have to target the antibiotic. That is what is better. Otherwise, if there is not possible to get a isolation of any culture, then yes, inhaled antibiotic do have some role if there is a structural lung disease, and they tend to have a pseudomonas, especially the colistin, tobramycin, and we have astreonum also. So these will help you. And before this, Vijay, I think one question which I saw during the chat, which I didn't answer, they asked what is the duration for long-term management. The duration for long-term management, again, it depends. For macrolide, we can give up to 3 months, 6 months, 12 months, different trials are there. But you have to keep on periodically follow up the patients with whatever prerequisites I have told you. You have to keep on evaluating for NTM, hearing, and QT interval. And for inhaled antibiotic, yes, you can go up to 28 days. And again, you have to reevaluate the sputum culture. And for the airway clearance technique and all, they can be given for as long as possible. That is not having any definitive time period. So it depends on different trial. So this is what the literature says about the long-term management.
Thank you, doctor.
ERTB. I think MDR-TB is already done, Vijay, I feel.
Okay.
Am I right?
We'll check and let you know, Dr.
Yeah,
Twinkle.
I think MDR-TB is already done. As far as I remember, MDR-TB is already done. So you can just go through the YouTube channel of Mediversal Academy and can check.
Yeah, please go to near to live section. There we have all the videos, all the webinars.
And definitely, I didn't cover hemoptysis in this because hemoptysis itself is a very important part, and I already covered in a webinar. If you guys want, you can go and watch that webinar again, and you can correlate here. There's a management of hemoptysis. Okay, in that also I have mentioned the bronchiectasis and the massive hemoptysis management, how to manage.
Thank you, doctor. Please, any questions if you have, you can drop in the chat box. Also, a small announcement: we have uh, back-to-back sessions planned for this week. No, just to have a sneak peek. On 18th Feb, we have an insight on puberty and disorder of sexual pubertal development by Dr. Poojalakshmi B. On 19th Feb, we have female pelvic anatomy by Dr. Reza Samuel. But on 20th Feb, we have from fundal eye to station practical fetal assessment in labor, Dr. Arshia Syed. On 24th, we have exploring the reversibles type 2 DM management and goals, Dr. Namonil Datta. On 27th, we have role of botulinum toxin, Botox, in cosmetology practice from Dr. Prachi Mishra. And on 28th Feb, we have PCOS, Dr. Reza Samuel. Please do follow us on social media. If it helps, I will also drop our social media channels categorized by, I will drop the link. Please do follow us on social media to know about all the updates of our upcoming webinars. We have really power packed session ahead, Doctor.
Yes, it sounds very interesting.
Yeah.
I hope all the participants are enjoying and will be eager to attend those webinar. They
Thank
are
you.
very wonderful topics, and it's a great job done by Mediversal Academy by sharing and imparting the knowledge. And they are just sucking the knowledge from the speakers and distributing it to the participants. That's a very good job, I feel, sharing the knowledge.
Thank you, doctor. Thank you.
Yeah, if there are any questions, we have time, so we can discuss. You can ask questions.
If anyone wants to come on audio,
Yeah,
you can unmute
yeah,
yourself and you can
yeah.
ask the question to doctor.
Yes, yes, definitely. You can also give your feedback, and most probably next month, I'm planning to take a webinar on pneumothorax. It's not yet decided. I'll just think and take about the pneumothorax, probably next month webinar.
Hello.
Hello?
Hello.
Hello, yeah, Rajesh, tell me.
Excuse me, sir. One patient is a 43-year-old. He have a severe dyspnea with every rainy season when it start monsoon with blank white cough sputum. What is diagnosed? It is allergic or anything else?
Black sputum or white sputum?
White, blank, white.
Okay, it's not purulent, right?
Yes.
Okay, and you are giving a history of seasonal variation, and you have
See,
to check.
yes. Just
Yeah, yeah.
in when every rainy season is start, then
Yes.
complaint.
That's what. When there is rainy season, there is a cold climate, the humidity increases. So yes, more likely it is allergic, but you have to rule out the infective causes by asking fever or any chest pain.
No. Just
Yeah.
only dyspnea and sputum.
Yeah. And did you ask about any wheezing, history of wheezing, and what is the age of the patient?
Yes. Wheezing also there.
Yes, age of the patient.
43 and
Yeah.
overweight also.
Did she respond to any bronchodilator or inhaled corticosteroid?
Yes. On steroid.
Like oral or inhaled?
Patient on steroid.
Yeah, you are giving in the form of oral steroid or inhaled, like a nebulizer or a
Inhaled. Pump.
inhale. Yeah, if she is responding to inhaler and she gives history of seasonal variation with dyspnea and wheeze, more in favor of allergy and bronchial asthma, not in infective part.
Yes, tomorrow.
Yeah. You can
Okay.
continue the inhaler even though the symptoms have subsided. Can continue for a month or 2 months, because tell her the symptoms may subside, but the inflammation will take time to subside inside the lung. If you just stop the inhaler in 15 days, 20 days, she may feel better, but the inflammation keeps on going, and that will have an impact on the lung health.
Yes. Okay. Thank you.
Yeah, thank you. Thank you very much, Rajesh, for the discussion. Anybody else?
Doctor, there is one more question. Can
Yeah.
bronchoscopic lavage help to eradicate pathogens?
No, it will not help to eradicate. It will just help you to clear the airway secretion, and it will help you to get a diagnosis. If the patient is unable to expectorate, or the sputum culture is not yielding any result, or if you are suspecting a tuberculosis, yes, then you can do a bronchoalveolar lavage, and you can send the sample which has taken from the lung, and that will help you to get a culture or diagnosis. Less likely it will help you to eradicate pathogen.
One more.
Somebody has asked pneumonia and pneumonitis. Pneumonia is an infection. Pneumonitis is an inflammatory response, like radiation pneumonitis. Okay, so pneumonia is particularly infection due to some organism. Pneumonitis is a inflammatory response. So that's the difference. And the symptoms may or may not, they overlap. Okay, and radiological features are also little different. Pneumonia, you will have more likely bronchopneumonia or consolidation. In pneumonitis, it will be infiltrates, more likely infiltrates. For example, radiation pneumonitis. Okay, so that's a difference. We cannot just tell labeled difference. These are some vague differences of pneumonia and pneumonitis.
Thank you, doctor. Dr. Aisha says thank you. Dr.
Thank you,
Solanki says
Aisha.
thank you.
Thank you, Aisha.
I think we are end of the session. Thank you so much for joining all.
Yes.
If I will drop again the certificate registration form. If you have missed, please do fill the form, or you can directly scan the QR code which is present on your screen. Thank you, doctor. On behalf of all the attendees here, I extend my heartfelt thanks to you for joining this evening and shedding your time on this particular topic. Thank you so much.
Thank you, Vijay. Thank you, Mediversal, and thank you everybody for patient listening. And I hope I have done justice with the topic. And I just want you all to implement these ideas into your private practice, whatever day-to-day practice is there, so that it will benefit your patients and to the community. That's it. Thank you very much.
Thank you, doctor. Thank you all. Please look out for all the upcoming webinars. Do visit our social media channels to know more about it. Thank you. Good night.